Hi, tonight's lecture is about diagnostic tests. That's chapter 25 in your textbook. This lecture isn't going to cover every single diagnostic test that exists. The purpose tonight is to talk about basic diagnostic tests that you will probably see on a regular basis. As we go through med-surg, you will learn other ones that focus on specific illnesses. Truth be told, it would be impossible to list and learn every existing diagnostic test. Besides, like everything else, by the time you learn them, there's going to be new ones. Diagnostic tests and examinations help make a medical diagnosis by either pinpointing a disease process or injury or ruling out possible diagnoses. That would be lab tests, which is blood, urine, sputum, stool, things like that. Radiology, which is your X-rays and imaging, CAT scan and MRI. Ultrasound, endoscopy, graphic recordings, that's your EKG, your EEG. Your aspiration procedures. Thoracentesis, paracentesis, lumbar puncture, and bone marrow. Before we get started on the specific tests, let's just go over some general pre-procedure responsibilities. Of course, these will vary based on whatever exam or test is being done. First, make sure there is a healthcare provider order and note the healthcare provider order. In other words, look at it, read it, and sign it. Occasionally, the nurse schedules the test. Usually, they're scheduled in radiology or the department where the test is being held. Assess for any allergies to seafood, dyes, or preparation that may be used for the test. And you'll see what I mean by that as we go on. But, for example, iodine and barium. Remember that seafood has a high iodine content. If a patient is allergic to seafood, it is a predictor that the patient will probably be allergic to iodine-based contrast dye. You must understand the test and the prep needed, first of all. Look it up if you don't. You will learn in general today, but you must always follow your facility's instructions. Instructions are going to vary from place to place. There may be a manual with instructions on your unit, or you may need to contact the department where the test will occur for instructions. Determine if a consent is necessary for the check. Determine if a consent is necessary for the test. Check to see if it has been signed by the doctor and the patient or patient's guardian. Nursing is not responsible for the initial explanation of the test and its risks and benefits. This is the doctor's responsibility. But you may need to clarify the explanation, simplify it, and answer questions. People often don't want to admit to the doctor that they don't understand what he said, so they'll just say yes, 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 and have no idea what's really happening. You have to know whether it's an invasive or a non-invasive test. An invasive test are those that utilize methods that invade the body during a procedure, like an incision, a penetration, or a puncture. Examples of invasive tests include cardiac catheterizations, endoscopic procedures, lumbar punctures or aspiration procedures, etc. Invasive procedures require a signed informed consent. Non-invasive tests are procedures that do not penetrate the skin or enter any orifices of the body. Examples of this would be an X-ray, an EKG, etc. Assess the patient's understanding of the test prep. If there was no consent necessary, then you may be the one responsible for explaining everything. Explain the test in terms the patient can understand. This is going to help alleviate anxiety. This may occur on the patient's unit in the hospital, in another type of facility like a nursing home, a doctor's office, or in the home if you're a visiting nurse. So it depends on the setting. Instructions may include information about where to call with questions, diet to follow and for how long to fast, meds to take, omit, or adjust, when to arrive and where to report, if a ride home will be necessary, explanation of the test itself and what to expect, what to bring. For example, you might need to bring another ostomy appliance, a cane, your medication, when the results are going to be available and how do you obtain them. And post-test instructions, what to do and what to report in follow-up appointments. Number 8, does the test require that the patient be NPO and for how long? After midnight, maybe it's 6 hours pre-procedure, 8 hours pre-procedure, or maybe not at all. Administer laxatives and enemas if applicable. And make sure pre-test if all the prep has been followed. It's important to find out now so the test can be canceled. It'll save the patient going through an exam that can't be completed, perhaps putting the patient at risk. For example, if a patient drank fluids or ate prior to an exam that requires sedation, it will save the hospital money. It saves everybody, patient, nurses, and doctors time, and prevents potentially inaccurate results. Call the MD before sending patients home to report the problem discovered. The equipment you need depends on the exam. If the test is being done in another department, then you obviously don't need to set up for it. If the test is being done at the bedside, then you'll be responsible for obtaining the necessary equipment, setting it up, getting the patient ready, and assisting the doctor. So you've got to know what equipment you need and where to get it. Is it in the clean utility room, the storeroom? Do you have to go to central supply? If a disposable kit or reusable tray is used, you must know what they contain so you can get the other things the doctor's going to need. For example, it's not good to pause pre-procedure midway through because something is missing. Uh-oh, I opened the debridement kit and there's no blade. Also, if some type of electrical or battery equipment is used, test it first to be sure it works. Arrange the room, the equipment, the lighting to suit whatever exam is being done. Have a red bag ready if you need it for trash and a trash receptacle. Have needed paperwork completed and available. General responsibilities during the test or exam. Prepare the patient's positioning and draping. Be sure another nurse knows where you are, that you're in with the MD, so they can cover your other patients and help you if needed. Example, it's good to know another nurse is available to grab something that you might have missed. Assist the doctor as needed by passing him things, holding vials, and helping to hold the patient in the proper position. Monitor the patient, provide emotional support, and report any changes to the MD. Knowing what the test involves helps you know what things to watch for. Post-test general responsibilities. Leave the patient safe. Monitor and assess the patient's condition after the test and monitor them closely for complications. Leave the patient clean and comfortable. For example, you may need to change the linen and gown or reposition the patient. Perform post-procedure nursing care depending on the test. Follow post-test orders, frequency of vital signs, checking the dressing. Provide post-test instruction to the patient, give them a written copy, and explain the follow-up instructions like the MD appointments. Reassure and support the patient. Again, tell the patient when results will be available and how to get them. Notify the HCP if there's any abnormal results. Patients are often very fearful and anxious about what the test will show. The nurse should be available to listen and allow the patient the chance to express their concerns. You also obtain specimens and deliver the specimens to the lab. You need to know how to collect the specimens properly and how to prepare them. Always know ahead of time. If you don't know, look it up. You need to know if the specimen needs to go to the lab right now or if it can wait. Specimens are labeled immediately after putting them in a container with the patient's name, date of birth, time, your initials, and the purpose of the test. If a doctor hands you a specimen is obtained, you must ask him what he would like it labeled as, and then repeat to him what he said to confirm his order. Fill out the appropriate lab slip, place the specimen in a biohazard bag, place lab slip in the pocket on the outside of the bag. Errors occur that compromise and invalidate tests. Incorrect prep. If the prep wasn't followed for whatever reason, it can compromise the exam. You may not have enough specimen volume, so the specimen can't be tested. An old specimen that sat around too long before it went to the lab. A mislabeled specimen. No label and no lab slip accompanying the specimen. Paperwork's not in the computer. And a drug interaction that could invalidate the results. Now we're ready to talk about specific lab tests. There are a lot of lab tests, and the material will at times seem overwhelming. This lecture is an introduction only, and you're not going to be expected to commit it to memory. As we go into med-surg, the lab tests that pertain to specific disorders will be discussed and fit into the place. Now you need to learn the basics. If there's a lab test I want you to learn for the test, I will tell you, and I will try to make it clear what things are important. You don't have to know every single test exactly, precisely, and I will let you know. You will learn these as we go. Laboratory tests are the first thing we're going to talk about. A laboratory test is an examination or analysis performed on some type of bodily fluid, like blood, urine, feces, spinal fluid, sputum, gastric contents, and bone marrow. It would be impossible to memorize every normal value for every lab test. You should start to familiarize yourself with some of the more common values. Values vary slightly with different labs. While you're in school, you should learn norms as listed in your text. I have included some normal values that you may often see, and you should learn them now. They may be on the test. The norms that I list are for adults. We're going to concentrate on the blood for this lecture. You already did urine in previous lectures, and the other things will come about as we go through med-surg. Quickly, the anatomy and physiology of the blood. The red blood cells, the white blood cells, and the platelets are produced in the bone marrow, and they're formed blood cells that circulate in the plasma. The plasma is a straw-colored fluid that's made up of about 92% water and 9% protein. Just to mention it, because these things will come up in lab results and in lectures, the protein would be albumin, globulin, and fibrinogen. Albumin makes up most of the protein content of the plasma, over 50%, and it's what gives the blood its thickness or its viscosity. Hence the saying, blood is thicker than water. Pardon the pun. The plasma is filled with red blood cells, white blood cells, and platelets, and it circulates throughout the body through the arteries and the veins. Hematology. Hema means blood, and ology means the study of. So, hematology is the study of blood cells, red cells, white cells, and platelets, and blood-forming tissue, which are the bone marrow. First thing is the CBC. A CBC is a complete blood count. It can also be a CBC with a differential, which they'll write as CBC with diff. A CBC measures leukocytes. Leukocytes are white blood cells. White blood cells are colorless. That's why we call them white blood cells. A high white blood cell indicates an infection. A low white blood cell indicates the inability to fight infection. The normal white blood cell count is 4.5 to 11.1. There's several different kinds of white blood cells. There's the neutrophils, which are the most prevalent white blood cell. The lymphocytes, which make up your B and T cells. The eosinophils that get high with allergy conditions. The basophils, which also are reactive with allergies, and the monocytes. So A through E, those are the 5 different types of white blood cells. If a CBC with diff is ordered, the test will differentiate or break down the percentage of each of the different white blood cells. This is going to become important later in diagnosing specific diseases, like leukemias and lymphomas, and you'll learn about those in med-surg. The second type of blood cell is your thrombocyte or your platelet, which is abbreviated PLT. Platelets are needed for clotting. Normal platelet count is 140,000 to 400,000. And the third type of blood cell is your erythrocyte or your red blood cell. Erythrocytes are red in color. Normal, vary with erythrocytes. These things are going to vary from male and female, with men being a little higher. For the normal male, it's 4.21 to 5.81, and females 3.61 to 5.1. The erythrocytes are made of hemoglobin. Hemoglobin, HCG, is the abbreviation. It's the iron-containing pigment of the erythrocyte that carries the oxygen from the lungs to the tissues. Hemoglobin measures the number of red blood cells that contain iron. So you're measuring the red blood cells that have iron. Iron's needed to transport oxygen. The normal hemoglobin is higher in men, and hemoglobin is the reason that the red blood cells are red. The iron makes them red. A norm in a male is 14 to 17.3, and in a female, 11.7 to 15.5. Next is the hematocrit. That's the percentage or volume of whole cells that consist it's the percentage or volume of whole blood that consists of red blood cells. Whole blood contains platelets, white blood cells, red blood cells, and plasma. So, the red blood cells are separated from the other components of the blood, and the percentage of the blood sample that is made up of red blood cells is the hematocrit. The normal hematocrit, again, is higher in men. If the doctor orders just a hemoglobin and hematocrit, it is often written as an H&H, capital H, capital H. Normal males, 42% to 52%. And females 36% to 48.5%. So that means that, for example, a female would have 36% of her whole blood sample is made up of red blood cells. A decreased red blood cell, a decreased hemoglobin, a decreased hematocrit are signs of anemia, hemorrhage, or fluid overload. And I did put in the back of your package an example of a lab result that shows a complete blood count. So you should know those values. The next test is the blood chemistry. Often see this written as a comprehensive metabolic panel, a CMP. You can see that in box 25.2 on page 509. A CMP provides info about the liver, kidneys, and pancreas. A CMP is done to rule out certain conditions and to diagnose specific diseases or conditions. The first one is your blood glucose or your blood sugar. That's going to be increased in diabetes. A blood glucose can be random, which means I could take it any time, or it can be fasting. A normal fasting sugar, blood sugar, is 70 to 100. It would be a little higher, and it would depend on whether you've just eaten, if the sample is random. The electrolytes evaluate the fluid and electrolyte balance and acid-base balance. Excuse me, let me go back. I skipped the normal for blood sugar, I think. The normal fasting blood sugar is 70 to 100. Electrolytes evaluate the fluid and electrolyte balance and acid-base balance. You learned all about this in chapter 29. I didn't list any norms here because I'm sure that Mr. Alves told you which ones you need to know. The next thing is CMP shows are some of the enzymes. Enzymes are released into the blood when there's damage to an organ. For example, when you have liver function tests, you'll see the liver enzymes are going to be high or raised. That would be the ALP or alkaline phosphatase, the ALT or alanine phosphatase, and the AST, the aspartate aminotransferase. You don't need to memorize those right now, just be aware of them. The blood urea nitrogen is also done in the blood chemistry. Nitrogen, if you remember, is an end product of protein breakdown, and it's excreted by the kidneys into the urine. And then the serum creatinine, which is the end product of metabolism, and it's also excreted by the kidneys. A high BUN and a high serum creatinine are an indication of kidney disease. The total bilirubin. Bilirubin is the waste product remaining after the liver destroys the old red blood cells. Bilirubin has an orange pigment. Excessive levels of bilirubin stain the skin and tissues an orange-yellow color, which you know is jaundice. Bilirubin levels evaluate liver function and block bile ducts, for example, gallstones. And then the total protein, that's the albumin and the globulin. That evaluates dehydration, burns, renal disease, liver disease, diabetes, and things like that. Other blood tests, again, specific lab tests are going to be discussed when we talk about specific diseases and disorders. I'm just going to mention a couple of them quickly. There's the hemoglobin A1C, or the glycosylated hemoglobin. That's going to show the percentage of glucose that's binded with hemoglobin A in the past 3 months. And that's a good indicator of the blood glucose control. I put an example of a lab slip at the end of the lecture, just, for you to look at. I won't be asking any questions. And then finally, cardiac enzymes. Those are enzymes that are released when there's damage to the cardiac muscles. Remember, whenever the enzymes are elevated in the liver function test, there's probably liver damage, and that would be the same with cardiac. The only other lab test I didn't include, but I'll mention it briefly, is the TSH, or thyroid stimulating hormone, because the thyroid stimulating hormone is a test that's very commonly done on a physical exam to see if the person has any thyroid problems. Usually a low level of thyroid hormones is what they're looking for. Next section, we finish now with the lab work. Now we'll move on to X-rays or röntgenograms. The purpose of an X-ray is to examine the soft and bony tissue of the body. The basic principle of X-rays is that different body structures have different densities. Dense structures such as bone are going to appear white when you X-ray them, whereas air-filled areas such as the lungs appear black. Organs and tissues appear as various shades of gray. So remember, the denser the tissue, the lighter it shows up on the film. Sometimes you worry about the risk of radiation. There is. Genetic alterations can occur if the reproductive organs are exposed to radiation. Cumulative effects of multiple exposures over the many years can cause problems. And a fetus during the first semester is especially at risk for genetic alterations. Lead aprons are worn by others in the room, and areas of the patient's body not being X-rayed are also covered with lead aprons, like the genitalia will be shielded. Lead aprons, I already said that, excuse me. Contrast media. At times, the diagnosis of certain conditions requires that visualization of details that cannot be visualized with plain X-ray film. So they have to be highlighted with contrast media. Contrast substances can be administered orally, rectally, or intravenously. The ideal contrast media should be relatively harmless, inert, and should not interfere with any physiological functions. But always be aware of the possibility of a reaction. Emergency supplies and equipment should be readily available. The types of contrast media that you're going to see with diagnostic testing are barium and iodine. And there is an iodine substitute, but we won't talk about that today. First, barium sulfate. It's radio-opaque and shows up white on the X-ray film. Barium itself is a white, chalky liquid that's given PO or per rectum, depending on the test. And it's used for GI studies. It effectively eliminates small filling defects that can't be seen. Clinically, you should keep in mind when barium is used, it's going to interfere probably with other diagnostic studies. Procedures using iodine contrast have to be done first before any barium studies, because barium is going to interfere with the visualization of the iodine. A laxative should be taken after a procedure when barium is used, because barium is not absorbed and it stays in the GI tract until it's eliminated. It's very constipating. Elderly and active patients should be checked for impaction if they fail to defecate after a reasonable length of time. And if someone has had barium, the stool should be observed for 2 days to determine if the barium has been evacuated. While the barium is still in the system, the stools are going to be light in color. After the barium is expelled completely, they'll go back to normal. Unless contradicted, encourage people to increase their fluid intake to help eliminate the barium, because it can, if unnoticed, cause a bowel obstruction. It should not be used for intestinal studies if the person has a suspected perforated bowel. Patients with ostomies require special considerations. And remember, for example, a person with an ileostomy should never be given an enema or a laxative. The next thing that we use for contrast are our organic iodines, which are also radio-opaque. They can be administered PO, IV, rectally, vaginally, instilled into a body cavity. Iodine is used for kidney studies, liver studies, blood vessel studies, urinary bladder, and urethra studies. There are adverse reactions that occur due to iodine-based contrast dye. They can range from mild, just the person feels nauseous and maybe vomits, or they can progress to a severe anaphylactic reaction where the person can actually have a cardiovascular collapse, central nervous system depression, and these things can lead to death if untreated or unnoticed. Reactions usually occur immediately or soon after the administration of the iodine. So it usually occurs in the radiology department, but it can happen that reactions can be delayed, so always watch for them. When iodine contrast is used, people who are allergic to contrast iodine must have this recorded in their medical record. People who are allergic to seafood are at a really high risk of an allergic reaction from iodine, because seafood contains a high content of iodine. So make sure this is reported to the MD if a person tells you they're allergic to seafood. When the dye is being injected, tell the patient they're going to feel a warm, flushing sensation and maybe feel nauseous when the dye goes in. This is normal. Determine if the patient is fasting In most instances, the patient is NPO the night before the study. And remember again, iodine media studies should not be done before barium contrast studies. Barium is going to interfere with the visualization of studies using iodine. For example, an IVP should be done before a barium study. After the test, if other conditions permit and the person has had iodine contrast, large amounts of oral fluid should be encouraged to promote urination that's going to flush the iodine out of the body. And remember, after the test, to monitor for delayed reaction. Common X-rays without contrast would be your chest X-ray. It's most frequently requested X-ray. I bet everybody here, myself included, has had a chest X-ray. They use them to diagnose pulmonary or lung disorders, done to determine proper position of devices such as a feeding tube or a chest tube or a central venous catheter. The procedure is pretty simple. A routine chest X-ray consists of 2 images, a frontal view and a left lateral view. It can be performed with the patient standing or in the high Fowler's position. Films taken in the supine position aren't going to demonstrate any fluid congestion levels, so that's not a good idea. If patient cannot be transported to radiology, a portable X-ray will be brought to the patient's room. There's no pre and post procedure care, no preparation, just an explanation of what the X-ray is. Another common X-ray is an abdominal film or a flat plate X-ray, which is called a KUB. So they're looking at the K for kidney, U for ureter, and B for bladder. So this is going to help in the diagnosis of intra-abdominal diseases. It'll help provide information about the size, shape, and position of the organs. And pre and post test, same as a chest X-ray. Some common X-rays that use contrast dye. I'm just going to give you a couple of them that use barium, since barium is something we just talked about. One is the upper GI series and small bowel series. So you want to explain to the patient an upper GI series includes the esophagus, the stomach, and the duodenum. If it's a small bowel series, the test is also going to visualize the jejunum and ileum. That's the lower 2/3 of the small intestine. You have the patient drink barium sulfate, and the patient is going to change position frequently. They do have barium in a lot of different flavors now, cherry, banana, whatever, but it still tastes like chalk. While they're doing the X-ray, they're doing a fluoroscopy. That means that images of the GI tract are projected on a fluorescent screen. The swallowed barium coats the GI structure, so the defects such as tumors or ulcers are seen as dark areas with a white background. An upper GI series is a test to help diagnose stomach and duodenal ulcers. As the barium goes through the small intestine, another series of X-rays may be taken. That would be your small bowel series. An upper GI takes about 45 minutes. If a small bowel series is done, it may take several hours, maybe up to 5. Also, a follow-up X-ray may be ordered in 24 hours. The patient prep, complete fasting from food and fluid is required from midnight until the test is completed. Afterwards, pre-test diet, activity can be resumed, food and fluids resume, administer laxatives as ordered. They've had barium, So, and observe and record the stools for color and consistency so that they can see, or you can see, when the evacuation of barium is complete. A barium enema, explain the test. It's done for the examination of the colon or large intestine. Specifically, an enema of barium is going to be given. An enema of barium is going to be given in the radiology department. The patient must retain the barium while a series of X-ray pictures are taken. The radiologist, with the aid of a fluoroscope, that fluorescent screen, watches the barium as it flows through the large intestine. X-rays are taken at the same time. After the barium is excreted, a final X-ray of the bowel is taken. Sometimes air is put into the empty colon for better visualization. They call that double contrast exam. When they do use air or induce air, it can cause some gas and slight discomfort. A barium enema takes about 1 to 1.5 hours. For a satisfactory exam, the colon must be thoroughly cleansed of fecal material. The presence of stool may make it very difficult to detect small polyps, as well as any source of bleeding. So the patient prep, the bowel is prepared according to radiology department protocol. It can be a little different. I already said, explain the purpose of the test. A barium enema is very tough on a person's modesty. Patients are often apprehensive and embarrassed, so offer reassurance. Written instructions and reminders are helpful for the prep. And the prep is probably a clear liquid diet before the test, stool softeners, laxatives, maybe enemas, and the person remains NPO after midnight. Post-care, diet and activity, the same, but this test can be very exhausting. People often feel weak, tired, thirsty, and hungry. So it's a good idea if they have somebody there with them. And laxatives should be administered for at least 2 days or until the stool returns to normal. So those are your 2 barium studies. The next test I'm going to talk about is an intravenous pyelogram, which is called an IVP. This is a test that we're going to use iodine-based preparation for. You want to explain the test. What is the test? It's used to visualize the kidneys, the ureters, and the bladder for evaluation of the structure and function. Iodine-based contrast is going to be injected IV. An IVP permits detection of structural and functional abnormalities that contribute to UTIs. Preparation, explain the purpose, the prep, and the procedure. Ask the patient and check the record for any history of an allergy to iodine or seafood. Notify the doctor if there's any chance of that. Make sure that assigned consent is in the patient's chart. Assess the renal and fluid status. Prepare the patient as specified by the radiology department. The prep is going to include a bowel prep plus restricted food and fluid for 8 to 12 hours before the test, because any gas, feces, or barium is going to interfere with the visualization of the kidneys, the ureters, and the bladder. That's because the kidneys lie behind the intestine. If there's feces in the bowel, the view of the kidney is probably going to be obstructed. And once more, schedule any barium studies after the IVP is completed. Inform the patient that as the dye is injected, a transient flushing or burning sensation will be felt, along with possible nausea, vomiting, and maybe a metallic taste. A rash, difficulty breathing, rapid heart rate, or hives may signal an allergic or anaphylactic reaction to the dye. Notify the MD immediately and the test will be stopped. After the test, observe for any late allergic reactions. Increase the fluid to get the IVP dye out of the body. Resume the normal diet and assess the IV site. The next thing I'm going to talk about are angiograms. An angiogram uses X-ray exams to study the vascular structure of the body. It involves the injection of an organic contrast solution like iodine through a catheter that's inserted into the femoral artery, and less frequently it could be the brachial artery. The catheter is selectively placed into the artery under fluoroscopic visualization by the radiologist. After satisfactory X-ray films have been obtained, the catheter is removed, and this is very, very important. Direct pressure is held on the puncture site until the bleeding is controlled. Remember, we're puncturing an artery, not a vein, so the blood is going to squirt out. It usually takes several minutes for the bleeding to stop. The other very important thing you should remember is the patient after this procedure should remain on bed rest completely flat for at least 6 hours, maybe up to 8 hours after the procedure is done. So the person lies completely flat. They may have a small pillow for at least 6 hours, maybe up to 8 hours after the procedure. During this time, flexion or bending of the joint adjacent to the puncture site is restricted. So, if I had my left femoral artery punctured, the left leg should stay in the straight position and not be flexed. The name of the study is derived from the vascular structure studied, as well as the specific vessel. But in general, it could be an arteriography, which is an arterial vessel, or a venography, which is a peripheral or central vein vessel. Post-care, the catheter puncture site must be observed frequently and closely for hemorrhage or hematoma formation. There can be serious complications that require immediate attention if this occurs, and you can imagine. Many of these patients have been receiving anticoagulants pre-procedure, and that would be part of the pre-procedure that would be part of the pre-procedure instructions, depending on the MD and the situation, to hold the anticoagulants for a certain length of time before the procedure is done. Secondly, vital signs, puncture site assessment, and neurovascular assessments may need to be done as often as every 15 minutes for the first 3 hours. Remember, the affected extremity must not be bent for several hours, and the patient must lie flat, except for a pillow under their head. Do not raise the head of the bed. This could put a strain on the femoral puncture site. The patient can turn, but when you turn a patient, you've got to make sure that the affected extremity is maintained in a straight position. If needed, a fractured bedpan can lessen the strain on the groin site. If bleeding or a hematoma do occur, apply pressure immediately to the site. Sometimes sandbags are going to be applied to the site as a routine part. Maintain a functional IV line. Things to be alert for that could be a warning of a big problem are the sudden onset of pain, numbness or tingling in the limb, coolness of the extremity, decreased or absent pulses, pedal pulses, or femoral pulses, blanching color of an extremity. These things are things that you want to notify the MD about immediately. They can signal an arterial occlusion or a blood clot. If the person had an arterial blood clot, it would require rapid surgical intervention. The next two tests I'm going to talk about, and I know you're all familiar with, the first one being a CAT scan or computed tomography. A CAT scan uses X-rays. A narrow beam of X-ray is passed through the body and a computer reconstructs the image. A CAT scan provides detailed cross-sectional images of the area being scanned. It could be the head, the chest, the abdomen, the spine, and the extremities. The term tomography, when broken into syllables, literally means tomo means cross-section, and graphy means to write or record. So a very clear image is produced of a cross-section of the area that's being studied. The test can take anywhere from 30 to 90 minutes. Contrast medium may be used, IV or PO. There may also be a bowel prep depending on what organs are being examined. You'd see that for the abdominal CT. The CT scanner is called a gantry. It's a circular, you know what it looks like. It's circular with a round opening. And the patient is strapped to a special table, and the scanner with X-ray tubes revolves around the body. Pre-test, explain. Assess NPO status if necessary. It depends on the test if they were NPO. Assess for allergies to contrast if it's being used. That would be iodine. Assess if the person's going to be able to lie supine for up to 60 minutes. Sedation and analgesics may be given to help the patient lie quietly. Assess for claustrophobia, although this isn't as big a problem as it is with the MRI. Remove hairpins, jewelry, and things like that, not because they interfere with the test, but they can get in the way. The CAT scanner makes a loud clicking noise. Give the patient earplug, and the test is painless. After the test, they can resume their diet, increase their fluids, especially if they had contrast dye, assess for delayed reaction to the contrast, and check the IV site if the contrast was given IV. Next thing is the MRI, magnetic resonance imaging. It's not an X-ray. What it is, it uses a powerful magnet to produce a very clear image of organs and tissues. Explain the procedure, ask them their weight. The reason you want to know their weight, if a person weighs over 300 pounds, the test cannot be done in a traditional MRI machine. They will probably need to go to an open MRI state. They will have to go to, if the patient weighs over 300 pounds, The test cannot be done in a traditional MRI. They're probably going to have to go somewhere that has an open MRI machine. For the procedure, the patient lies down on a movable exam couch after a thorough medical history is obtained. Sedation may be and is often necessary if the patient is claustrophobic or can't lay still. Ear protection helps eliminate that knocking sound that comes from the scanner. Two-way communication system is always available between the patient and the operator. It makes people very claustrophobic because it's so small and tight. Plus your head goes in first, so you feel like you're at the end of the machine. You can't see anything, and the fear is that you won't be able to get out if you get claustrophobic. So it's important to let them know that someone is listening. They can say they need help, and the exam can be stopped if they become claustrophobic. Because when you get, again, the machine that goes over the person, just like with the CAT scan, is called a gantry. And that's the part that's frightening. Even the open ones, which are more like a CAT scan, it's hard to lay in a machine for a long period of time. A non-iodinated dye may be injected IV for better visualization of the anatomy. The dye they use in the MRI is very low toxicity and has fewer side effects than X-ray contrast agents. But still watch for allergies. You wonder why they don't use this in X-rays. It isn't effective with a traditional X-ray. You wouldn't be able to see what you're looking for. There's no pain or discomfort associated with an MRI. The exam varies from an hour to an hour and a half. There's no specific dietary instructions or special preparation. However, when you have an MRI, there are numerous safety factors. Some things are absolutely contradicted. If you have an implanted device, you shouldn't have an MRI. I mean, a pacemaker, a cochlear implant, some prosthetic devices, implanted drug infusion pumps, neurostimulators, bone growth stimulators, and even IUDs. Internal metallic objects like metal fragments from bullets, shrapnel, surgical clips, pins, plates, screws, metal sutures, or wire mesh. You should not have an MRI. And MRIs are not advisable for pregnant women or individuals with seizure disorder. All patients should be advised to remove the following before entering the MRI suite: hearing aids, dentures, jewelry, hairpins, wigs, hair pieces, dental bridges, credit cards, keys, shoes, belts, or clothing with metal fasteners needs to be removed. They probably would give you a Johnny. Postcare, assess for delayed reaction to the contrast media, which is uncommon, but watch for it. Assess contrast injection site for any infection, inflammation, bruising, or irritation. And increase the fluid intake and resume the diet. Next are ultrasound studies or sonograms. You want to explain the test. An ultrasound is a non-invasive procedure for visualizing soft tissue structures. It's often used in conjunction with X-ray or nuclear medicine. It's relatively quick. Could only take a few minutes. It may take up to an hour, though. What happens is an ultrasound beam is directed into the patient's body and passes through it. The body tissue will reflect the sound waves with varying degrees of intensities. These varying sounds or echoes, waves are electronically processed, reflected, and displayed. Recordings of these displays may be made for documentation on a variety of media, including X-rays, video disc or tape, digital media, or paper. They're very safe, there's no harmful effects, and they're painless. They use no radiation and no contrast dye. During the procedure, a gel is applied to the skin over the area to be examined to conduct the sound waves. An operator, a sonographer, holds a microphone-like device called a transducer. You remember that, the transducer, when you check the pedal pulses. The transducer is moved over a specific body part that is viewed on a monitor. Sound waves echo back through the transducer and an image is formed on the screen. Certain ultrasound tests are best performed with a full bladder. The patient may be asked to drink 4 to 6 glasses of fluid 1 to 2 hours before the exam and refrain from voiding, which is tough after you drink all that fluid. Some exams require the patient to fast. After the test, there's no restrictions and no problems. Specific exams that are ultrasound, you've heard of an echocardiogram. That's an ultrasound of the heart. There's abdominal studies, you're usually NPO for those. Gallbladder, liver, you're NPO. Thyroid, renal, urinary bladder, usually the person has to have a full bladder to begin the exam, and it's emptied to complete the exam. Obstetrical, any of you that have had an ultrasound to see your baby and to check on the baby and the sex, usually they ask you to have a full bladder. And a prostate exam. When it's a prostate exam, they're probably going to ask the man to self-administer an enema, like a fleet enema, 1 hour before the exam to eliminate any fecal material. And you know, Doppler, we did it in lab before we had to stop doing lab for COVID. But Doppler method of ultrasound is used to establish blood flow through the blood vessels, like we did to detect the pedal pulses. Endoscopic procedures. The examination and inspection of body organs or cavities by means of an endoscope. An endoscope is a fiber optic instrument that is used for direct visualization of certain internal body structures by means of a lighted lens system attached to a flexible tube. The procedures are done for diagnosis of pathological condition, for treatment of a condition, such as the removal of tissue or foreign objects. All endoscopic procedures begin with the name of the area being examined and end with the suffix oscopy. There are many endoscopic procedures, such as a bronchoscopy that visualizes and examines the trachea and bronchi, an esophagogastroduodenoscopy, an esophagogastroduodenoscopy, which visualizes the esophagus, stomach, and duodenum, a gastroscopy that looks at the stomach, a sigmoidoscopy that looks at the sigmoid colon, and a colonoscopy that visualizes the entire colon. General principles of all endoscopies: they're invasive, you need an informed consent, you have to explain the procedure, it's performed in a special room in the endoscopy department, it's performed with light sedation or conscious sedation to alleviate discomfort. There is minimal or no discomfort during the test. The patient is awake during the procedure, but because they had conscious sedation, they usually don't remember anything after they were sedated. Their NPO 6 to 12 hours prior to the procedure. Vital signs are assessed prior, during, then every 15 minutes for 1 hour after the procedure until stable. After stable, then every hour for 4 hours. After an endoscopy, monitor the patient closely for signs of possible perforation of the organ that was scoped. An EGD, which is esophago, which is the esophagus, gastro, which is the stomach, duodenal, which is the duodenum, plus scopy, which is the endoscope that we're using. It's done for detection and biopsy of polyps, ulcers, and tumors of the upper GI tract. Before the procedure, you get an informed consent, the person's NPO for 8 to 12 hours. You have the baseline vital signs. You want that in case there's changes. You give mouth care prior to the procedure to reduce the microorganisms in the mouth because the scope is going to go through the mouth. Remove dentures, partial plates, and check for loose teeth. Remove glasses and contact lenses. Resuscitation and suction equipment is available at the bedside where the procedure is being done. You administer pre-meds for the part of the conscious sedation. Mouth and throat are sprayed with a local anesthetic. After the procedure, remember you're going to monitor the vital signs every 15 minutes for an hour until they're stable, then every 4 hours. Monitor the person for respiratory distress and assess cardiac, respiratory, neuro, and GI systems. Whenever anybody is having a endoscopy that involves going through the throat, it's very, very important to check for the return of the gag and cough reflex. Before that returns, instruct the patient not to eat or drink anything until the effects of the anesthesia have worn off and the cough and gag reflex returns. It usually takes about 2 to 4 hours. If food and fluid were consumed while there was no gag or cough reflex, the patient is at an extremely high risk for aspiration. Make sure the patient has an emesis basin to expectorate sputum and saliva. Monitor the color character of secretions. It's normal for secretions to be blood tinged for a few hours after the procedure, especially if the doctor did a biopsy, but notify the doctor if it looks grossly bloody. And then monitor for signs of perforation. That would be difficulty swallowing, severe pain, epigastric, pedonal, shoulder or back pain that increases with movement, dyspnea or cyanosis. Of course, report it immediately. Tell the patient that a low-grade fever often develops during the first 24 hours as a result of the inflammatory process, as a result of the procedure. The throat is inflamed from the instrumentation. Teach the patient that a sore throat and or hoarseness of the voice are common after the procedure. Throat lozenges and or warm saline gargles are going to help. Now, although I specified an EGD, keep in mind that the pre- and post-procedure guidelines will basically be all the same for all endoscopic procedures where the endoscope is inserted through the mouth. So that would be a bronchoscopy, a gastroscopy, etc. Before we leave endoscopic procedures, I want to talk about colonoscopies. Colonoscopies you hear about pretty commonly. What it is a flexible endoscope is inserted into the rectum and through the colon to visualize the large intestine. It may be performed to evaluate constipation, particularly if the problem is acute and a tumor or obstruction is suspected. It's recommended by the American Cancer Society to be done at the age of 50 and routinely thereafter every 5 to 10 years. Suspicious lesions can be biopsied and small polyps can be removed during a colonoscopy. It identifies precancerous and cancerous lesions so they can be removed before they spread. The preparation for a colonoscopy: make sure that an informed consent has been signed. Check the hospital policy for withholding food and fluid. Usually a liquid diet is prescribed for 1 to 3 days prior to the test, and the patient will be NPO for 8 hours before the procedure. Instruct the patient on dietary restrictions and bowel prep. The bowel prep is going to vary according to the physician's preference, but in general, the colon must be empty and clear to be visualized. So, it'll be clear liquids 24 hours pre-procedure, and the patient should be instructed to avoid ingesting any red liquids. No red Jell-O, popsicles, things like that. Laxatives start about 2 p.m. the day before the test. Some doctors order enemas the day before. Conscious sedation is going to be used. The exam takes 30 minutes to 1 hour. Patient is going to be positioned on the left side and then turned on the back. The scope will be advanced to view the entire colon. Again, a biopsy can be done, polyps may be removed, and the discomfort is minimal. The uncomfortable part of a colonoscopy isn't the exam, it's the prep. Post-test, observe closely for signs of perforation. Report any abdominal distension, rigidity, pain, or rectal bleeding. That could be signs of perforation. If a person has a polyp removed, tell them to do no heavy lifting for 7 days and avoid high fiber food for 1 to 2 days. A sigmoidoscopy is similar to a colonoscopy, but a lot simpler. It examines just the lower section of the colon. A light diet is usually ordered the evening before, and the patient does not need to be NPO. Enemas or rectal suppositories may be given. The procedure is quick. It only takes about 15 minutes. The positioning may be knee, chest, or for the elderly on their left side. The scope is inserted in advance just through the sigmoid colon. One more thing before we leave the endoscopy. There's a thing known as a capsule endoscopy. During a capsule endoscopy, the patient's going to swallow this tiny capsule that contains a camera. And as the capsule is swallowed, the camera goes through the digestive tract. The camera is going to take thousands of pictures that are going to be transmitted to a recorder that's worn around the patient's waist. This is going to allow visualization of the small intestine, which can't be seen very well with EGD, and it can't be seen actually, or with colonoscopy. They use it to determine the location of GI bleeds and diagnosis of bowel disorders like Crohn's disease or celiac disease. The camera will be expelled in the toilet approximately 8 hours after it was swallowed. Although rare, a camera may remain in the body and have to be surgically removed. This is important to know so that you monitor the bowel movements until the camera is excreted. Graphic recording tests. They detect abnormalities in the electrical activity of the heart, the skeletal muscles, and the brain. The first one I'm going to talk about, you all know, that's an electrocardiogram or electrocardiography. It can be abbreviated as an ECG or an EKG, and that's skill 25.2 in your book. It's used to detect injury or malfunction of the heart. It provides a graphic recording of the heart's electrical activity. It tracks how long it takes for the electrical impulse to travel through the heart's electrical pathway, from the sinoatrial node through the atrioventricular node to the bundle of His, the Purkinje's fibers. And there is a diagram of that. The electrical activity is analyzed from 12 different angles. The patient teaching, explain the purpose of the test, position the patient in a semi-Fowler's, a supine position, remove the clothes on the upper body, put on a Johnny, remove jewelry. 10 electrodes are applied. Conductive gel is applied to each electrode, unless the electrode comes pre-lubricated. 6 electrodes are put on the chest. 1 electrode is applied to each extremity, so 1 on each wrist and 1 on each ankle. The electrodes are attached to lead wires, which are connected to a recorder. Tell the patient to lie as still as possible during the procedure. The test only takes 10 or 15 minutes. It's painless. After the procedure, remove the electrodes and clean the skin with alcohol or a damp cloth to remove that icky, sticky conductive gel residue. And there is a picture of the normal sinus rhythm. If you look at an EKG, and I'm not going to take much time with this, you'll learn more about this in the cardiac unit. But each box represents the length of time it takes for the electrical impulse to travel to the designated sections of the conductive pathway. So the P wave shows depolarization of the atria. The QRS complex shows depolarization of the ventricle. The T wave is repolarization of the ventricle. Depolarization is when your heart contracts. So when it's contracted, it is depolarized. Polarization is when the cardiac muscle is at rest. And repolarization means the heart muscle is recovering from a contraction and trying to reach the polarized state. The heart muscle must be fully at rest or polarized before the muscle can be stimulated or depolarized again. Another test that you do that's also a graphic study is an exercise stress test. An EKG cannot conclusively detect reduced blood flow to the heart, so an exercise stress test may be ordered. During an exercise stress test, heart function is monitored by a continuous EKG while the patient is exercising on a treadmill. The patient is going to continue to exercise until the heart rate reaches 80 to 90% of the maximum rate normal for the patient's age and gender. Should symptoms develop, like if the person develops chest pain, the test is stopped. If a patient is unable to tolerate exercise, the patient will be given IV meds that can recreate what happens to the heart during exercise. If that is the case and meds are given, it's called a chemical stress test. Another test that we use that's a graphic recording is the EEG, or electroencephalogram, cephalo being your head. The explanation: it's used to detect abnormal brain function. It provides a graphic recording of the patient's brain. It provides a graphic recording of the brain's electrical activity by showing the brain waves. And it's very useful in evaluating seizure activity. To prepare the patient, explain the procedure, emphasizing the importance that the client stay still and cooperate. In children, it is necessary to have them asleep during the test. Therefore, you keep your child awake during most of the night so that he or she will sleep during the test. You don't have to be NPO, but you have to withhold food, fluids, and medications that may stimulate or depress the brain waves. That would be seizure medications or anticonvulsants, tranquilizers, depressants, and caffeine-containing food like coffee, tea, cola, and chocolate. Patient teaching: the test takes about an hour. It's painless. It's going to be performed while you're sitting in a chair or lying down on a stretcher or bed. The electrodes are applied to the scalp with a thick paste. During the test, the patient's going to be asked to breathe in and out deeply for a few minutes. Then the patient will close their eyes while a light is flashed on them. Finally, the patient will lie quietly with their eyes closed. This way, different electrical activities can be detected and picked up. Aftercare: the main thing that you should remember if you're taking care of a person that just had an EEG is to get their hair washed. Wash that sticky, icky conducting gel out of their hair. It's awful. It looks like they've had a conditioning treatment on steroids. So make sure to wash their hair. The third graphic study I'll mention briefly is a myogram. Myo means muscle. A myogram traces the electrical activity of muscles as they contract. It's done to assess function of muscles and nerves. A small needle is inserted into one or more of the affected muscles. The electrical activity of the muscles is registered when the muscle is contracted. The reading is transmitted and recorded on a monitor. Before the test, inform the patient that they will feel slight discomfort when the needle is inserted because it does hurt. Aspiration procedures. An aspiration procedure is going to include a thoracentesis, a paracentesis, a lumbar puncture, and bone marrow studies, or bone marrow aspiration. To aspirate means to withdraw or remove, just like when we talked about aspirating the needle. We pulled back on the needle to see if we got a blood return. Aspiration procedures, however, withdraw fluid or air from a cavity with a needle. Aspiration procedures are invasive and an informed consent is needed. All aspiration procedures involve setting up a sterile field. Make sure the patient understands the procedure. Usually the thoracentesis and the paracentesis and other puncture studies are done at the bedside. So the nurse is the main assistant. She assists the physician by setting up the sterile field, drawing up the local anesthetic, cleaning the injection site, and assisting the patient to the proper position. Throughout the exam, the nurse reassures and supports the patient emotionally. And you also have to help the patient maintain the proper position until the procedure is complete. After the procedure, apply pressure to the injection site for about 5 minutes to prevent bleeding. And once the bleeding is stopped, apply the appropriate dressing. Label the specimens and get them to the lab appropriately. The first one we're going to talk about is a thoracentesis. Thora means thorax or check. Thoracentesis, thora means thorax or chest. Centesis means cavity. So therefore, thoracentesis is done to remove fluid from the pleural cavity or the pleural space for diagnostic purposes or to reduce respiratory distress resulting from excess fluid. It's an invasive procedure in which fluid, occasionally air, is removed from the pleural space with a needle. You know this already, but I'll just review it quickly. The pleura is a double-layered membrane that surrounds the lungs. And there's 2 layers. There's the parietal pleura, which is the outer layer, and the visceral pleura, which is the inner layer that lays against the lungs. In between those 2 layers is the pleural space, and that's where we're getting the fluid. So the fluid is aspirated and analyzed for abnormalities. When the fluid in the pleural space is significant and interferes with respirations, which you'll learn more about when we do the respiratory units, but when this is the case, thoracentesis is the treatment of choice to remove the fluid. It may be performed at the patient's bedside, it could be a procedure room, or it could be done at the MD office. Local anesthesia is used, and the procedure takes 30 minutes. The amount of fluid removed is limited to 1,200 to 1,500 milliliters at one time. That's because if you take too much fluid, cardiovascular collapse can occur. And cardiovascular collapse occurs from either too rapid removal or too much fluid being removed. A pneumothorax, which is the accumulation of air in the pleural space, is a possible complication if the needle being used punctures the visceral pleura. Before the procedure, ensure the patient has signed an informed consent. Assess the patient's understanding of the procedure. No sedation or fasting. A cough suppressant may be ordered if indicated. There's a thing called a thoracentesis tray and needles and supplies. It may all be in the tray, but you have to check. Set up your sterile field. Obtain baseline vital signs, and auscultate the breath sounds. Apply supplemental oxygen and a cardiac monitor, and weigh the patient. Assist the patient to an upright position, leaning forward with the arms and head supported on an anchored over bed table. So they're going to be in the orthopneic position. I showed a picture of that. Inform the patient that although the local anesthesia is going to eliminate most of the pain, as the needle is inserted, they're going to feel a sensation of pressure. The needle is called a trocar, and the trocar has an adapter an open adapter where you can connect tubing to it, and the tubing is connected to a collection bottle. After the procedure, monitor the patient's pulse, color, and other vital signs. Apply pressure to the puncture site for at least 5 minutes to prevent bleeding, then apply a dressing over the puncture site. Remember this, position the patient on the unaffected side. So the side that was not punctured is the side they should lie on. This allows the pleura on the affected side a chance to heal. Label the specimens appropriately and send them to the lab for analysis. Weigh the patient again so that you compare the pre-procedure and post-procedure weight, which is an indication of how much fluid was removed. During the first several hours after the procedure, assess and document vital signs, respiration status, lung sounds, cough, any blood in the sputum, and check the puncture site for bleeding. Keep a close eye on the client for dyspnea or arrhythmias. A chest x-ray must be done to detect possible pneumothorax after. And normal activities generally can be resumed after 1 hour if no evidence of pneumothorax or other complications are present. A paracentesis, again, it's going to be the removal of excess fluid, but this time from the abdominoperitoneal cavity. So it's going to be the removal of excess fluid. When a person has liver disease or any fluid that they're holding in their abdomen, it's known as ascites. It's generally reserved for severe ascites. That's when the fluid accumulates in the peritoneal cavity, and it's usually due to chronic liver disease. To prepare the patient, verify that the patient has signed an informed consent. Weigh the patient prior to the paracentesis. Assess the vital sign for baseline. Have them void prior to the test to prevent bladder puncture. Position the client in a position the patient in a sitting position, either on the side of the bed or in a chair, and support the feet. In this position, the intestines float back and away from the insertion site. The intestines drop down so that when the needle goes in, they aren't there in the way. Explain what to expect during the test. During the procedure, blood pressure and other vital signs are monitored. After you clean the puncture site and the local anesthetic's been administered, a small incision is made and a needle known as a trocar is inserted to withdraw the fluid. Actually, the needle makes the incision as it punctures the site. Can't separate these last 2 pages. I might be here forever. Okay. The trocar is connected to tubing, which is connected to a collection bottle, and specimens are sent to the lab. During the test, support the patient emotionally and help him to maintain that position. It's very difficult to stay still during these procedures. After the procedure, apply pressure to the needle site or the puncture site for at least 5 minutes to prevent bleeding. Then a dressing is placed over the puncture site. There may be some fluid leakage from the site. Then weigh the patient and compare to the pre-procedure weight. Measure the abdominal girth. So when you measure abdominal girth, you take a tape measure and across the widest part of the abdomen, you check the abdominal girth. And you should have also checked the abdominal girth pre-procedure. And you'll see a significant difference in how large it is. And then, of course, monitor vital signs, same as in a paracentesis. The next test is a lumbar puncture, an LP, or a spinal tap. It's usually done to obtain cerebral spinal fluid, CSF, for examination. To prepare the patient, you need an informed consent. Ask the patient to empty their bladder. You obtain their baseline vital signs. Then you position the patient. And again, it's really important that you know what position the person should be in. So help the patient to assume a lateral recumbent position near the side of the bed. The patient assumes kind of the fetal position with the knees flexed toward the head and the head bent toward the chest, with their hands clasped around their knees. And that way their back is bowed, and I did include a picture in the outline. Patient teaching and care. Let them know a local anesthetic is going to be injected into the skin over the area of the needle insertion. This med may cause a burning sensation, and the patient has a feeling of pressure when the needle is inserted. The needle, the trocar, is a long, thin needle, and it's inserted into the lower back below the level of the spinal cord, between the third and fourth lumbar vertebrae. And then CSF is withdrawn. The CFS pressure is measured with a calibrated tube called a manometer. There's going to be or might be slight pain down one leg during the procedure, but it's very important for the patient to remain still. A small dressing or Band-Aid is used to cover the place where the needle was inserted. After the procedure, the patient is to remain flat in bed for the number of hours prescribed, usually 6 to 8, but it can vary. Check with the person to see if they're having headaches and medicate them as ordered. Headaches could be caused by the loss of CSF and the size of the needle. Monitor and record vital signs and neurostatus. As we've said before, apply pressure to the puncture site for 5 minutes to prevent bleeding. Check the puncture site for leakage of CSF or any hematoma. And encourage increased intake of fluid, up to 3,000 mLs in 24 hours. And lastly, and I'm sure you're sighing a big sigh of relief that I said that, I'm going to talk about bone marrow studies. Specimens can be obtained either by aspiration or biopsy. The preferred site is the posterior iliac crest, but the sternum can be used. Aspiration is performed by inserting the needle into the middle of the bone and drawing out a sample of the blood in the marrow. Biopsy is performed by making a small incision over the bone and screwing a core biopsy instrument into the bone to obtain a specimen. It's used to diagnose leukemias, metastatic neoplasms, lymphoma, aplastic anemia, and Hodgkin's disease. It takes about 20 minutes. A sedative may be given prior to the procedure. And although the area is anesthetized, the insertion of the needle may be painful. The site of aspiration is probably going to ache for a day or two. That's normal. To prepare the patient, assess for any alterations in clotting, check their lab work, determine if the patient understands the purpose and procedure, record the vital signs, ask the patient to void, position the patient in the supine position if aspiration is to be obtained from the sternum, or anterior iliac crest. Position the patient in the prone position if the posterior iliac crest is to be used. And assist the patient to maintain this position during the procedure. After the procedure, apply pressure to the site for 5 to 10 minutes, then apply a dressing. Assess vital signs and compare with baseline, and do that for however many hours are required, as we said earlier. Monitor for bleeding and infection, and inform the patient to report any unusual bleeding immediately. So that concludes the lecture on diagnostic testing. Don't be freaked out by it. I'm not going to ask you to know every detail of this. You should know the lab results that I told you about. You should know about the general procedures, like with barium and contrast dye. You should know the positioning of the patients and the nurse's role. Mostly, if I ask any questions, they would be on the nurse's role, except for the things I've specified. In the back of the packet, there is an example of lab work that was done. I put a CBC. I put a complete metabolic panel. I put an A1C. And also, I put an example of a prep, the prep that someone was given for a colonoscopy. This was done in Sturdy Hospital, so you can read through that. That is it. I hope to talk to you soon. I hope to see some of you at my office hours next Thursday. Stay well and stay safe.